diseases. By the end of this session, you will be able to describe the antibody-mediated nephritis in relation to fixed glomerular antigens, glomerular nephritis associated with immune complexes, and finally, immunopathological mechanism of glomerular nephritis to trapped glomerular antigens. So since this one word has been used quite a lot, are all of you aware of what is glomerular nephritis? What does this term means? Very good. The start is great. Inflammation of the glomerulus. Now, related to this, so the first around 5-6 slides are very important because I'll try to build up the clinical, the morphological, the immunological mechanism, and then later on there are 4 cases that we'll be discussing. So this is the format of today's lecture. So try to focus on the different terms, otherwise it will be a little difficult to understand the remaining part. So the first thing is, what is glomerular nephritis? Inflammation of the glomerulus. Now this itself can be of 3 different types. It can be focal, it can be segmental, and then finally it can be diffuse. So for example, this is the kidney, here is the region, I'm just roughly drawing if there is a glomerulus here. So if one particular area is involved, all the glomeruli that are here, if they are all involved, this is called as focal. Okay? But if the glomeruli of here, 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 so just it's scattered, that will be called as diffuse. Okay? And then segmental is if a part of it, a specific part, that will be called as segmental. So these are the 3 terms you have to remember as far as the glomerulonephritis is concerned. Then when we are talking immunological mediated diseases, they are to the fixed glomerular antigens or the antigens which have come from the periphery. So for example, the basement membrane of the glomerulus, it has got proteins. If the immune system target them, those are fixed glomerular antigens. But if the antigen was in the blood, maybe any bacteria or any other protein, and it went and got trapped in the glomerulus, that will be trapped glomerular antigen. We will see the examples, then you will understand further. Immune complexes, we have talked a lot about immune complexes. It is type 3 mediated response. Antigen binds to antibody. These antigen antibody complexes, they got deposited in different parts. They can deposit in the joints, they can deposit in the kidneys. So when they deposit in the kidneys, they result in damage, glomerulonephritis. And the 3 examples that we'll be focusing on is post-streptococcal glomerulonephritis. A part of it I explained in the molecular mimicry. Today we'll go further. Lupus nephritis. In type 3 hypersensitivity, I talked about it. Today we'll little bit go further. IgA associated glomerulonephritis. The details about IgA I talked in the mucosal immunity. So we'll go further from what you have learned so far. And then finally there is one more category that is called as vasculitis associated nephritis. So vasculitis is the inflammation of the blood vessel. So the Bowman's capsule has got tuft of capillaries, yes? If those capillaries are inflamed, they will result in glomerulonephritis. Okay? So the inflammation of the small vessels in the Bowman's capsule, when they got inflamed, that is normally associated with polyangiitis. So this is a clinical term. Polyangiitis means the inflammation of small vessels, especially the capillaries of the Bowman's capsule. When they get inflamed, it will result in glomerulonephritis. So these are the 3 different categories that we'll be dealing with today. Now here, this diagram here says renal biopsy, and here say added features. Now to make sense out of it, I'll just write down certain things and then gradually we'll see. So a kidney patient, when he comes to a clinic, what are the possible complaints or symptoms or signs that you see in a kidney patient? Pain, okay, flank pain is very important. blood in the urine. What is it called? Hematuria. Yes, blood in the urine. Very good. What else? Protein in the urine. Yes, that is called as proteinuria. Sometimes the patients say that there is difficulty in micturition, painful micturition, okay, or burning micturition. That is called as dysuria. Then sometimes the patients say that there is not enough urine. You know, the quantity of the urine is very less. Oligouria, excellent. Or somebody said something, polyuria, too much frequent urination. Now with this, there is one very important feature. The patient tend to have swelling of the body, edema. Yes. Now, why does that happen? Excellent. So the loss of the protein in the urine, there will be loss of oncotic pressure and the blood flows out into the tissues and there is edema, especially periorbital, around the eyes, and the tibial edema. Now these things have been classified into two groups, two words. One is called as nephrotic syndrome, and one is called as nephritic. Now there is a combination of some of these symptoms which are present in the nephrotic, some of these are present in the nephritic. For example, in the nephrotic, what is the most special thing? More than 3.5 grams per day protein is lost in the urine. This is the more than this protein is lost every day in the urine. So when there is too much protein lost, what will they have? They will have edema. Now, contrary to this, here it is definitely less than around 2 grams per day, and there is more prominent hematuria. Okay, so these are more specific ones. Then later they might have dysuria, they might have edema, these patients. But what is the bottom line? The patient can have nephrotic syndrome, they can have nephritic syndrome, but based on these signs and symptoms, you cannot reach your diagnosis. That's the problem. Okay, so the kidney patients cannot, from this, now if I tell you, is this patient IgA nephropathy, is he anti-basement membrane disease, or is it post-streptococcal glomerulonephritis, it won't be enough. Okay, so what you have to do, you have to dig in more into the history, and we'll see, I'll show you what are the different points in the history, how you will reach your diagnosis, plus you do a renal biopsy if it is needed, of course. Okay, on the renal biopsy, then there are two components. One, you will look for morphology. So what particular morphology you see? Is it humps? There is too much cellularity, too many cells have come there. Are there special spike formation is there? So you relate the morphology with immunofluorescent staining, so you can stain them specially for complement proteins C3, C4. You can stain them for IgG, IgA, and that will confirm your diagnosis. Okay, so there is a set pattern that you have to follow. You start with the symptoms, then if it is not conclusive, of course you have to go to the biopsy, and of course the clinical history of the patient, that we'll see how it is useful, and then in the biopsy you will do check the morphology, and then finally the immunofluorescent staining, and then you decide which particular disease is this. So far we are all okay. Now look at this diagram, whatever I explain here. Now I'll try to put it up here. So for example, antigen antibody mediated glomerulonephritis, it has got three main findings. Either it will be linear staining on immunofluorescent. So you can see here, it is a renal biopsy. Either they have linear staining, either they have granular staining, or they have minimal immune complexes deposition. So for example, if I kind of, in a glomerulus, if the staining is that of a typical linear pattern. So that one example is anti-G GBM, glomerular basement membrane staining, will be linear. Why? Because the basement membrane is a very intact structure. If the antibodies will attack them, so they will be lined up straight, and that's why you have a linear staining. But the other conditions, they have got just granular staining everywhere, like granules, small dots. So the other category, granular staining, has got big group. The anti-GBM is very clear, linear staining, but the granular has got all these. Now we will discuss anti-GBM, and then we will discuss three more important ones. These three: IgA nephropathy, lupus nephritis, post-streptococcal glomerular nephritis, and each one has got something special. So for example, IgA, on the immunofluorescent you should be able to find IgA. None of the other granular staining will have IgA staining. So that is very important for IgA. Lupus serology. First, the patient must have systemic lupus erythematosus features. All the features, the malar flash or butterfly rash, which we call, or the joints, symmetric involvement of the joint. There is a long history of the disease. We'll see how that is. So you link the features of lupus with the granular staining, and then you say, yes, this is lupus nephritis. The patient has developed. Finally, if you see the post-streptococcal, so what does post-streptococcal means? After the bacterial infection. So there must be a history of sore throat, pharyngitis, skin disease, skin infection, bacterial skin infection, and then you are looking for the features of granular staining. So this is just to tell you how you will move on from the symptoms to the staining or morphology and finalize your diagnosis. Now the question arises how the damage takes place in the kidney by the immune components, whether it is fixed antigen or it is granular antigens, trapped antigens or immune complexes. The first thing is, you can see immune complexes, they are going to cause type 3 hypersensitivity, ANCA antibodies. Now I gave you the example of vasculitic inflammation or vasculitis. One of the autoantibodies that can be seen in vasculitis is called as ANCA, anti-nuclear cytoplasmic antibody. ANCA is a specific antibody for vascular damage. Okay, so whether it is immune complexes, whether it is ANCA antibody due to the vascular damage, or specific antibody to the trapped antigen, or autoantibodies to the glomerular basement membrane, any of these, what it is capable of, if it is IgG and IgM, which component of the immune system will be activated? Complement system. MAC formation can take place, C3a, C4a, C5a. What are they called as? Anaphylatoxins. They can call other immune cells towards the site of inflammation. So one important thing is that whether it is IgG or IgM, they both are able to activate the complement. And then C3a, C4a, C5a, these can attract the neutrophils. Okay, and then at the same time they are also able to cause release of cytokines. Which cytokines? IL-6, IL-1, TNF-alpha, and also vasoactive amines, histamine, bradykinin, prostaglandin, all those are called as vasoactive amines. They will cause effect on the blood vessels, on the bronchioles, peripheral vasculature. So all these things are going to cause damage. With any of these antibodies, what they are going to do? They are going to release mediators, complement activation, polymorphonuclear cells will come, kinins, vasoactive amines, cytokines, they will be released, and finally there will be damage, and the damage will be seen as nephrotic syndrome, proteinuria, renal failure, hematuria, any of these. There is not fixed pattern. Lot of these diseases have overlapping features. Okay, another overall aspect that you need to remember is that these immune complexes or this damage, it can cause a particular staining pattern What are those staining patterns? One of them I already told you, that the granular one, this 1A and 3A. You can see three dots. So this is the granular pattern at the glomerulus here and at the tubules here. At the same time, linear staining can be seen like this, like a straight line. This one, 3B. These are straight linear staining. And then these are the mesangial cells. What are the mesangial cells? Yes, but what other, what is their location? So this is glomerulus, isn't it? So where are the mesangial cells? Okay, these are the blood vessels, capillaries. Between blood vessels and the visceral membrane. So this is the visceral membrane. So here should be mesangial cells. Actually, for mesangial cell, remember, it's like the stalk, So from the stalk, the branches go out of a tree. Okay. So when the capillaries come in here, they make a small stalk here at the entry, like the hilum. Of course, the glomerulus will not have a hilum, but I'm just giving you an example that this part will have maximum mesangial cells. So they make a supportive core. Okay, so here you can see the staining of the mesangial cell. That is also specific for certain diseases. So overall, just I wanted to show you that you can have granular staining, you can have linear staining, or staining of the mesangial cells. Now, the next thing that you need to remember is that how the immune complexes, or why the immune complexes cause this different type of stainings. How do they reach there? So it's just logical, very simple. So for example, this is the endothelium, this is the basement membrane, and these are the podocytes or the epithelium. Are we all okay with this structure? Okay. No? Yes? Yes. So if the immune complexes are intermediate or small sized, these immune complexes are going to cross all the first two layers, whether it is the endothelium or the basement membrane, and will get deposited here. But if they are large size, where they should deposit? Basement membrane. And that is how it will look. So if it is on the basement membrane, it's on the inner side. If they cross the layer, it will be on the podocytes' foot processes. So this is why they have different formations. They can result in the subepithelial humps. Do you know what is a hump? Like the back of a camel. Okay, so you can see these look like humps because they are just trapped in the foot processes of the podocytes. So with all this information so far, there is one last thing that I will add, and then we'll see the cases. That the complement protein we talked about, immune complexes can activate them, and that activation will be either of classical pathway, can also activate the alternative pathway, and will result in damage. But at the same time, just remember, bear in mind that the complement proteins are also very important for removing the immune complexes from the body. Yes? So the large immune complexes, so if there are large immune complexes, they will be deposited. That's why the complement protein try not to have large complexes. And alternative pathway is able to make them small pieces as well. So both the features, one is done by the classical pathway, one is done by the alternative pathway. So in the end, your body is kept clean by the immune complexes, again with the help of complement protein. So they are causing damage, but at the same time they are also protecting your body from these. So what happens in this whole process? The complement proteins are used up, because when they will be disrupting the immune complexes, helping them to be removed, cleared from the body. So if lot of immune complexes are formed, lot of the complement proteins will be used and their levels will be reduced. So remember this thing, that with immune complex diseases, the complement protein level give you an important finding, and that is that if the immune complexes are formed, if the complement proteins are used up, C3, C4 levels should be less. It should be reduced. Okay, so now we'll go to the scenarios. The first scenario, a 9-year-old boy brought to emergency with puffiness of face, eyes, trunk, a week. Previously, he had complained of sore throat. So on examination, he is pyrexial with temperature, hypertensive, anemic with normal WBC count, urine analysis show proteinuria, hematuria, and red cell casts. Raised anti-streptolysin O titer normally are less than 300 international units, but he has around 1600 international units. Complement proteins were very low. What is the role of anti-streptolysin O in this case? First, do you know which case is this? Post-streptococcal glomerulonephritis. Very good. The patient has got sore throat. So then, as I said, the features of kidney disease can have puffiness of the face, eyes, and then urine analysis show proteinuria, hematuria. Anti-streptolysin O, what is this? Yeah, but what is streptolysin? Which bacteria we are talking about? Excellent. Gram negative or positive? Does it produce exotoxins? What are they called? Streptolysin. So the exotoxin it produces is called as streptolysin. O, I'll tell you why. Why it is called as streptolysin? Because if you have this enzyme with the red blood cells will be lysed. That is why it is called as streptolysin, and O is oxygen dependent. Okay, so in these patients, antibodies are actually produced against the streptolysin O. But when the bacterial infection is gone, their structure, streptolysin O structure, is very close to what? The heart as well as the kidney. So they start attacking the glomerulus. And as a result, there is damage to the glomerulonephritis. Why do you think the complement protein level have reduced? Antigen antibody complexes will activate what? Complement proteins. More and more use will reduce the complement level. Should we perform a renal biopsy? No. Because we have reached the diagnosis based on what? Based on the history of the patient. It's a small boy with the sore throat, post sore throat. So whether it's a duration of 1 to 3 weeks or 2 to 6 weeks depending on skin infection or pharyngitis, and then he has got features of all these. Streptolysin O titers are very raised. So first thing is, the first logical thing is to put him on antibiotics and supportive therapy, and then monitor his complement levels as well as his anti-streptolysin O titer. If both of them is reduced over the time, it means your patient is recovering and there is no need of biopsy. But if with the antibiotic and supportive therapy the patient is not recovering and he is becoming aggravated condition, then you should think of biopsy. So acute post-streptococcal glomerulonephritis, 90% of the cases are between the age of 2 to 14 years, 10% are more than 40 years of age, and it is also seen after impetigo and post-streptococcal pharyngitis, bacterial infection of the skin or pharyngitis. The time duration is different. In case of pharyngitis, it's just 1 to 3 weeks later, and in case of skin infection, it is 2 to 6 weeks. The treatment, it includes supportive therapy with control of hypertension, edema. Dialysis is needed sometimes because too many autoantibodies are there, and then antibiotic treatment is must, not only for him but also the people who are living with him, the children, other children. And there is no role of immunosuppressive therapy even when there are very strong lesions. So you cannot give them immunosuppressive agents. The next case, a 39-year-old woman was diagnosed with SLE 20 years ago. She developed the clinical features after the birth of her second child. This pregnancy was complicated by proteinuria. The patient had polyarthralgia, alopecia, and erythematous rashes of the face, arms, legs. A renal biopsy was performed because of her urine analysis revealed proteinuria and RBC cast. What to expect on renal biopsy? Yes. Which kind of staining you would expect? Granular? Linear is in only one type of condition, anti-GBM. Granular staining. How antibodies mediate damage in this particular condition? So first of all, I'll just repeat what are the, do you all know what are the features of SLE? Excuse me. Butterfly rash on the face, photosensitivity. When the patients go out in sun, they have got these rashes are increased. Most importantly, are they males or females? Because the ratio is very high, 9:1. You know, the 9 times it is more common in female as compared to the males. So the female patients. Then another very specific relation is with pregnancy. In the pregnancy, SLE features are reduced. After the pregnancy is finished, the features again become aggravated. Okay? Then it will take time for the lupus nephritis to develop. You know, so the first they will have other features, joint pain of both the hands, like it's symmetrical on both the sides. There can be, you know, involvement of the skin. There are skin lesions, and then later on they develop skin. So everything is kind of put it here. So first there is a chronic history. 20 years ago the patient was diagnosed. Then they have also mentioned the childbirth, so the relationship with the pregnancy. They have also mentioned the arthralgia, pain in the joints, and of course you cannot diagnose such patients without biopsy. So biopsy is must. You did the biopsy. Now the thing is, what other antibodies are linked with SLE? In what is the, you know, background cause? They say there is too much apoptosis of the cells. As a result, nuclear antigens are released in the patients. Those nuclear antigens will have anti-nuclear antibody, anti-double-stranded antibody, anti-Smith. There are a lot of them, but these two are very important. So in this, in the beginning, I showed you that you have to link it with the clinical history and other findings. So you know that it's a SLE patient because of the features and the serology. Then you did a biopsy, and how they are causing damage. Again, that's typical first figure that I showed you. The immune complexes, complement activation, nuclear, the other mononuclear cells will come there, and they will cause damage through cytokines and other mediators. Now, special thing about SLE patient is 30 to 50% of the patients, they are having lupus nephritis at the time of presentation, out of which 60% are adults, 80% are children. And what is the stepwise mechanism? Immune complex formation that leads to complement activation, leukocyte infiltration, and finally the release of various cytokines will cause damage. Again, hypocomplementemia. What does that mean? C3 and C4 will be reduced. With acute lupus nephritis in 70 to 90%, renal biopsy will have different variants, but one thing is for sure, it will have granular staining and crescents on biopsy. Now we'll see all these features in this figure. You can see on this simple histology, these black dots are lot of immune cells have come there. Okay. Then on this particular figure, this is immunofluorescent staining. You can see the granular staining, lot of staining granules. And finally, on electron micrograph, you can see these are subepithelial hump, which I showed you in the animation. So all the features will confirm it's a lupus nephritis case. Another one, who would like to read it? No one? after learning project exercise.